Oh, 22 to 26. 2, 2, 2, 6. Oh, that's cool.
That's an easy one.
That's good.
A lot of 2, so
Lots of 2s.
bicarb.
So 2, 2, 2, 2, 6. All right. Now, let's look at those, and let's look at our examples. In the first example, the pH is in what direction?
Down.
Down, so draw a little arrow down in the box next to it. Then the rule says to look at what? The bicarb, and the bicarb in this case is in what direction?
Down.
Down, so draw a little arrow down. Are those arrows going in the same direction?
Yes.
So what adjective must you use?
Metabolic.
Metabolic, and because the pH is down, it is?
Acidosis.
So that is an example of metabolic
acid.
acidosis. Okay, look at letter B. Bicarb is in, the pH is in what direction? Up. Bicarb, up. Are they both in the same direction?
Yeah.
Yes. So what adjective must you use? Metabolic. So this is metabolic alkalosis. Is everybody with me? Okay, the next one, pH is down, bicarb is up. Are they both in the same direction? No. So what adjective can you not use? Metabolic. So you have to use respiratory. So this would be respiratory acidosis. Now the only time this doesn't work is when there's a mixed acid-base disorder and boards doesn't go there, because that's way too hard. All right? So if the pH, does everybody see how the rule works? What if I gave you a pH of 7.50 and a bicarb of 25? 750 and 25. What would it be?
Respiratory alkalosis.
Respiratory alkalosis. Why?
Because the
pH is in what direction?
Is low.
Well, 750 would be
yes,
up.
It's up.
And the bicarb is
Down.
normal. 25. It's normal.
I thought it said 30.
25. So is that the same direction? Up and normal?
No.
So it's got to be respiratory. So even if the bicarb is normal, it still works. You see what I'm saying? Alrighty, that's the ABG interpretation. Let's talk about signs and symptoms, letter B. They will tell you a patient has respiratory acidosis, metabolic alkalosis, something like that, and they'll say, what would you see? Select all that apply. And you get a whole laundry list of stuff, and you have to select, check, check, check what's true. Well, two things here. One thing here, I hate lists. One thing you're going to see in my review is I do not have you memorizing lists of things. I hate lists, I despise lists, I refuse to remember lists. The reason why I hated lists in school was for two reasons. First reason I hated lists is, for example, if I learned 15 signs and symptoms of hyperkalemia and then 15 signs and symptoms of hypokalemia, when I took the test, guess what would happen? I'd memorize, I would remember the lists, word for word. I could reproduce the list, but I would forget which one was which. Do you see what I'm saying? And when that happens, you're dead. All that work went for nothing. The second reason why I hated lists was, even if I could remember which was which and all 15 signs, my teachers had the tendency to pick signs numbers 16, 17, 18, and 19, and not the 15 that I memorized. And one thing that you guys learned real early in nursing is every book says something different, right? Take 2 nursing books, same thing, look at the list. The lists aren't the same, right? Have you ever found 2 lists that were the same for anything in nursing? Never. So you can memorize a whole bunch of lists, but for that to be productive on boards, it better be what? The list that boards is using, right? And what chances is that? Very slim. So the point is this, boards does not test your knowledge of lists. It does not. What boards test is your knowledge of principles, not lists. But how will they test your knowledge of principles? By having you generate lists. Do you understand what I'm saying? Boards will not test your knowledge of what? Lists. They test your knowledge of, but they will test your knowledge of principles by having you generate lists. And so when people take boards, they say, oh, you got to memorize a whole bunch of lists. No, you don't. They don't know what's going on. For example, in general, what do pain meds do? In general, what do opioid pain medications do in principle to a person? What do? They sedate you, don't they? They're CNS depressants. Okay, now, they will ask a question like, your patient is on Dilaudid, an opioid analgesic. What of the following things would you expect to see if they got too much or that they were getting a little too much? Select all that apply. Alrighty? And you're thinking, oh my goodness, I don't remember the list of Dilaudid signs. It's not a list of Dilaudid signs. It's to see if you know that opioid analgesics are CNS depressants, sedatives. So when you go to the list, what do you select? Agitation or lethargy? Lethargy. Flaccidity or spasticity? Reflexes of +1 or +4? +1. Hyperreflexia, hyporeflexia? Hyporeflexia. Restlessness or obtunded? Well, you go, I know what restless is. That's up, so obtunded must be down. That's a good test taker right there, okay? And you say obtunded. Okay, a good test taker never says, what? They say, And then they figure it out the other way. The thing about you guys that aren't good test takers, you haven't figured out that those good test takers, they don't know anything. They don't know anything more than you know. In fact, they probably know less than you know. They just don't quit. They just figure, oh, I'll get it. If they won't let me in the front door, I'll go in the back door. And if the back door's closed, I'll go through the cellar window. And they'll figure a way to get at it. They just don't quit. Poor test takers go, oh, I don't know what that is. No, don't do that. I had a student that was a really bad test taker. He came to a maternity question, and it said, what's the best way to treat morning sickness in a first trimester woman? And he said, oh, this is the only OB question I know the answer to. It's crackers. And he was so excited, and he got the one OB thing he didn't know. So it's crackers, crackers. You look, A didn't say crackers, B didn't say crackers, C didn't say crackers, and D didn't say crackers. And what did he say as a bad test taker? What did he say? Oh my goodness. I thought I what? Knew this. I guess I don't know this. So he picked something like antacids every half hour. Okay? And then he wonders why he doesn't do very well. Well, you know what number C said? You know what answer number C said? Dry carbohydrates. Well, what is a dry carbohydrate?
Cracker.
A cracker. But what did he do? Oh! He was expecting the front door, cracker. No, you go to the back door. Dry carbohydrate. Do you see what I'm saying? Don't give up. Don't think that you don't know this. You know it. Okay, so if they say restless versus obtunded, you know what restless is. Obtunded must be the other. Okay, but do you see what I'm saying about the sedation? And you generate the list by applying the what? Principle, not having memorized some list. Does that make sense? Do you see why why can't boards test lists? Why can a national nursing test not test lists? Because what? All the lists are different in different textbooks used in different geographical areas of the nation. To write a statistically significant, reliable, valid question, you have to write the question so that no matter who takes it, no matter what book they read, no matter what school they went to, it's a fair question. And if you're just taking out a Mosby's book on whatever, the signs and symptoms of whatever, and you write a question on that, it will perform horribly statistically nationally. The only way you can do these select all that applies and have them perform well is to test what? Principles, and see if a student can generate a list from a principle. Now, does that change the way you might look at a select all that apply question? You understand what they're about? There is no mystery. You weren't supposed to have memorized some mystery list that you didn't know. You're supposed to say, this is a chance for me to show I know a principle. You got that? That's how you do those. Okay. So, I want to give you a principle for answering acid-base signs and symptoms. And it's what's in the box there. It says, as the. Do you see where I'm at? As the pH goes, so goes my patient. As the pH goes, so goes my patient. What? What does that mean? As the pH goes. pH can go up, or the pH can go down. And when the pH goes up, your patient goes up. And when the pH goes down, your patient goes down. Does that mean they sink and levitate? No. What does it mean? What's it mean? Talk to me.
Not very excited.
Yeah, so when the pH goes up, every system in your body gets more irritable. But when your pH goes down, systems in your body shut down. So when your pH goes down, you shut down. When your pH goes up, everything gets hyperexcitable. It's pure chemistry. It's talking about catalyzing chemical reactions, basically. So, do you see where it says up? Oh, except for potassium. I'm sorry, I didn't write that in there. Except for potassium. So what does that mean?
pH goes up, potassium goes down.
And when pH goes down, potassium goes up. Because if it followed the rule, we wouldn't even mention it, right? So as the pH goes, so goes my patient, except for potassium. So if your patient goes up, do you see the little box there that says up? What is that? What's another name for that? Up pH? Alkalosis. What will you see with alkalosis? Give me some stuff. Give me some signs you'd see with alkalosis.
Vomiting.
Irritability, absolutely.
Hyperreflex.
Hyperreflexia. What would be some numbers that would be hyperreflexic? What numbers? 3 and 4. 3 and 4 are hyper. 2 is normal. 1 and 0 are hypo. Remember that with reflexes? 3 and 4 are high, hyper. 2 is normal, reflex, and 1 to 0 is hypo-reflex. What else would you see with alkalosis? You got 2 of them.
Irritable.
We got irritable, we got hyperreflexia. What else do you think? Think of a body system and then go a high. Tachypnea. What else? Tachycardia. Would you have paralytic ileus or borborygmi? Good. You good test takers said borborygmi, even though you may not know what it is, because paralytic ileus sounds like everyth's what? Shutting down. That would be the down. The up would be borborygmi. Now, Boards loves the word borborygmi. B-O-R-B-O-R-Y-G-M-I. Borborygmi. That is the word they will use for increased bowel sounds. So if you hear somebody's stomach growling this evening, what will you say? How borborygmus. Borborygmi. Increased bowel sounds.
Can you spell that one more time?
B-O-R, and do it again, B-O-R-Y-G-M-I. Borborygmi.
Nice.
So what would be down? Acidosis. And what would you see there? What's that?
Hyperreflex.
Hyporeflexia. What else?
Bradycardia.
Bradycardia. Lethargy. By the way, obtunded means just one step more lethargic than lethargy. O-B-T-U-N-D-E-D, obtunded. Vocabulary is critically important to pass this test. That's why the blue book and the yellow book are real heavy on vocab. Can't answer a question if you don't know what the words mean. Sounds pretty obvious. So what would you have, paralytic ileus or borborygmi? Paralytic ileus. Would they have a seizure or a coma?
Coma.
Coma. Because seizure's up, coma's down. You got to go the same as the pH. So let me ask you this. What acid-base imbalances are most likely to seize, and which ones are most likely to have a respiratory arrest? Alkalosis will what? Seize, and acidoses will respiratorily arrest. Does that make sense? Because you're doing the, as the pH goes, so goes your patient. So what acid-base disorders need an ambu bag at the bedside? What acid-base imbalances need an ambu bag at the bedside? Acidoses, because they're going to what? Respiratorily arrest. Which acid-base disorders need suction machines at the bedside? Alkaloses, because they could seize and aspirate. See, don't limit yourself. When they start asking these things, say, wait a minute, I know about this. I can get there. See, I shouldn't have to teach you who needs an ambu bag at the bedside. You should be able to get that from as the pH goes, so goes my patient. Do you see what I'm saying? These rules, use them. They're tools. Okay? Before we turn the page, I want to ask you, I want to introduce you to, whoa, that's bright. Don't look at the light. Is that coming in clear? Or, oh, duh. I want to introduce you to my favorite Scotsman. You know how Scottish surnames have Mac, Dougal, McDonough, MacGyver, MAC? You know? My favorite Scotsman, Mac Kuzmal. How many have heard of Kuzmals? Okay, from now on, I want you to, every time you see Kuzmal, I want you to think what? Mac Kuzmal. In fact, if you're talking to a doctor and he goes, he's Mac Kuzmal, I'll be happy. It'll make you look stupid, but I'll be happy. The reason is Kuzmal's is a compensatory respiratory pattern for one and only one acid-base disorder. You only see Kuzmal's with one of the 4 metabolic disorders, one of the 4 acid-base disorders. Which one? Well, MAC tells you that. M for what? And AC for acidosis. So MAC Kuzmal tells you that you see Kuzmal's with metabolic acidosis. Okay, we have some knowledge, but we have to be able to what? Apply it. Remember, you can't apply what you do not know, but what you know, you have to be able to apply. This says, your patient has respiratory acidosis. Select all that apply. +1 reflexes. Diarrhea. Dynamic ileus. Spasm. Urinary retention. Paroxysmal. Atrial. Tachycardia. 2nd degree. Mobitz. Type 2. Heart block. And hypokalemia. I want you guys to get in groups 2 and 3, right where you're sitting, you don't have to move. I want you to talk to somebody, your buddy, and I want you to answer this question. And I want you to use the rule that I taught you. The rule is what? As the pH goes, so goes my patient, except for potassium. Now I really want you to draw some arrows here. I want you to draw arrows. Okay, and I want you to get the answer. So you can do it yourself, then turn to your buddy, discuss it, and then we'll talk about it. And don't say any answers out loud. Okay, how many did you select?
How many did you get?
3.
I got 3. I know, I don't know. Yeah, 3.
How many did you select?
3. 4.
3. You should have selected 4.
Fourth.
So let's play our game. What should you automatically notice about this question? It said what?
4. Acidosis.
Acidosis, the pH is in what direction?
Down.
And everything's going to go the same direction, which is what direction?
Down.
Except for potassium, which is going to go
Up.
So a high K. So now there's your answer. Now, up or down?
Down.
Select or no select? Yes. Up or down? Select or no select?
No.
No. Adynamic, without movement. Up or down?
Down.
Down. Select or no select?
Select.
Select. Spasm, up or down? Select or no select? Urinary retention?
Down.
Down. Select. Paroxysmal atrial tachycardia, select or no? No. Mobitz type 2 heart block, yes or no?
Yes.
Why? Block means the impulse is being what? Slowed, blocked, it's down, it's being hindered. So that's a select. Hypokalemia? No, I want a high K, not a low K. So the answer is the +1 reflects the adynamic ileus, the urinary retention, and the second degree Mohs type 2 heart block. How many got that right? Excellent, excellent. Did you memorize the list? No? How long would the list be before you got second degree Mohs type 2 heart block? Right? Okay. So that's what, and they're testing what principle? What principle are they testing? That in an acidotic environment, chemical reactions cease. So everything shuts down, and that's why you do it, see? You weren't supposed to have memorized these. Do you see what my point is? So this should kind of free you from the fear of these select all that applies. Oh, by the way, what's the number one mistake that people make with select all that apply? Most common mistake made with select all that apply questions.
Not even
Selecting one more than you shoulda selected. Number one problem. Now, those of you who are real concrete people, I did not say answer what you think and take away one. Okay, I didn't say that. I said that the tendency for people is to answer what? One more than they should. So here's the deal. With the select all that apply, if you know it's two of them, what do? Select those two and what? Stop. Because if you go, well, you know, it could be, okay, now that's a killer on select all that apply. You know, could be, don't go there with select all that apply. That is not cool. Because you're heading down a road that's going to get too wrong. If you do not know that it applies, do not answer select all that. You know what I'm saying? If you don't know that this is true, then don't pick it. Is that making sense? All right. The other thing about select all that apply, it's never only one and it's never all of them. You see what I'm saying? Never answer just one on a select all that apply, and don't answer all of them on a select all that apply, because it's never one and it's never all of them. Okay. Let's go to the next page. Causes of acid-base imbalance. Causes. What they'll do is they'll give you a scenario, and they'll say, this is what's happening to your patient. And then they'll say, what acid-base disorder would result from this? Do you see they're flipping it around. Instead of saying, what sign and symptom will the acid-base balance cause, they're asking, what will cause the acid-base imbalance? And one thing that people do wrong when they answer these kinds of questions is they get signs and symptoms and causation messed up. Do you realize that in the human body, oftentimes what causes something is the opposite of what the signs and symptoms of that thing are? Does everybody understand what I'm saying? So a lot of times what will happen is diarrhea will cause a metabolic acidosis. But once you get acidotic, it will shut your bowels down and you will get a paralytic ileus. Do you see, one diarrhea caused it, paralytic ileus results from it. It's the opposite. And when you're sitting there going, man alive, I learned it was this, and now you're telling me the opposite, probably what are you messing up? Causation versus sign and symptoms. So make sure that many times if you go back and you do questions now and you get confused, think, wait a minute, are you talking about sign and symptom, or are they talking about causation? Then you can go, oh, I see where the problem is now. Does everybody understand that? Okay. So just keep that straight. Okay. Having said that, we're talking about causation now. Whenever you get a scenario, the first big question you ask yourself is it lung? That goes in the first blank. Is it lung? L-U-N-G. Is the scenario a lung scenario? If the scenario they give you is a lung scenario, guess what kind of a problem it is?
Respiratory.
It's respiratory. I mean, it can't be any easier than that. However, that only gives you a 50-50 because it could be respiratory acidosis or respiratory alkalosis, correct?
Right.
Well, how do you tell between those? Well, the second question you ask yourself is the client overventilating or underventilating? Is the client or patient overventilating or underventilating. That is going to be critical for your respiratories. If the patient is overventilating, pick alkalosis. If they are underventilating, pick acidosis. Now this is extremely simple. It's almost pathetically simple. Are these not the only 4 options you have to choose from when you combine them to make these imbalances? It's either metabolic or respiratory. It's either acidosis or alkalosis, right? So you're choosing between these 4 words, correct? Well, let's look to see how this works. If the client is overventilating, let's take the word ventilate. Which of these 3 words fits best with the idea of ventilating? Exactly. Now, we're left with what? Over. Of the remaining 3 words, which word has the closest connection to something being over? Why alkalosis? Because it's over the normal. So that's alkalosis. So if you put them together, ventilating over becomes respiratory alkalosis. See how easy that is? And if I say the patient is under ventilating, what does vent become? Respiratory. What does under become? Acid, because that's under the normal. So under vent becomes respiratory acidosis. You see, you're just translating. You're just translating. See that? How many understand what I'm saying? Okay, do you see how easy this is? You're simply translating. So when they say overventilate, you say, oh, respiratory alkalosis. Underventilate, respiratory acidosis. So let me ask you this. They give you a scenario where a woman is overzealously using her breathing techniques during labor. She's really overzealously using those breathing techniques. What acid-base disorder would she exhibit? Well, is that lung? Yes, she's breathing techniques. Overzealous using breathing. So that's lung. Is she overventilating or underventilating? Overventilating. You translate that to mean respiratory alkalosis, and that would be your answer. You have a child who was a victim of near drowning. What acid-base disorder would it be? Well, is that a lung scenario? Near drowning? Yes? Would the kid have been overventilating or underventilating when he was nearly drowning? Under, so he would have respiratory acidosis. Your patient has emphysema and air trapping. Is that lung?
Yeah.
Is he overventilating or underventilating? Under, so he would respiratory acidosis. Be careful. Ventilating doesn't mean respiratory rate. The respiratory rate is irrelevant here. Everybody pays way too much importance to the respiratory rate. Do you understand that ventilation has to do with gas exchange, not respiratory rate? For example, I could say that a person had pneumonia in 4 lobes of the lung. Pneumonia in 4 lobes. They're breathing at 50 a minute, and their SaO2 is 78 on 8 liters per mask. You got it? What do they have? Pneumonia in 4 lobes. They're breathing really fast, but their SaO2 is really low. Now, is that person overventilating or underventilating? Under, even though their rate is 50, because rate has nothing to do with it. And everybody pays so much attention to rate, they miss these questions right and left and don't understand why. Because you're paying attention to the wrong piece of information. It's not about the rate, it's about the SaO2. Would you agree with me that if your SaO2 is good and you're breathing slow, you're fine, but if you're breathing fast and your SaO2 is low, you're actually underventilating? So the rate can be tricky. So what am I trying to tell you? When you get acid-base disorder questions, what piece of data in the question is real shaky to use to get your answer? Respiratory rate. Because a lot of times it compensates, which means does the opposite, so you'll totally get the wrong answer. You see what I'm saying? Pay attention to what? SaO2. All right. Somebody's on a PCA pump. What acid-base imbalance would tell you that maybe they need to come off that thing? They're on a PCA pump. What acid-base disorder would tell you they need to maybe come off that thing. Well, you say, okay, well, PCA pump, what do you know about PCA pumps? They what? Depress respirations. Why would they need to come off of it if they were, what? Getting too much, which would make my respiratory rate go really what? My ventilations go really down, which would mean I would be under ventilating. So the answer would be respiratory acidosis. So respiratory acidosis would tell you that maybe you need to back off that PCA pump. Is that making sense? And see, those are questions you may not have even thought you know the answer to, but you can get the answer if you just calm down and use it. Because this is a what? It's a tool. So use the tools at your disposal. Don't say, I can't get the screw out, and the screwdriver's still sitting in the box. You know, grab the screwdriver and try to get it out. So many times I teach people tools on how to take tests and everything, and then I do test questions with them, and they leave the tools in the box. You know what I'm saying? Get the tools out. Start using them. What if it's not lung? The next box says, what if it isn't lung?
Metabolic.
Then it's metabolic. If it isn't lung, it's metabolic. Well, good news. There's really only one scenario where you will answer metabolic alkalosis, and that's what the next fill in the blank says. It says if the patient has prolonged gastric, vomiting or suctioning, pick metabolic alkalosis. Why? Why does prolonged gastric vomiting and suctioning lead to metabolic alkalosis? You're losing acid. If you lose acid, you become basic. Otherwise, everything else that isn't lung, you pick metabolic acidosis. For everything else that isn't lung, that's another fill in the blank. For everything else that is not lung, pick metabolic acidosis. So let me ask you this. A patient had GI surgery. He has had a NG tube to low intermittent GOM co-suctioning for 3 days. What acid-base disorder would he most likely exhibit? Metabolic alkalosis. Your patient has hyperemesis gravidarum. What acid-base disorder are they most likely to exhibit? Metabolic alkalosis. Your patient with hyperemesis gravidarum is now dehydrated. What acid-base disorder would they have? Now they've gotten dehydrated. That's not prolonged gastric vomiting suctioning. It's something you see with it, but it isn't what it is. So now what would they have? Metabolic acidosis.
Because it caused that.
Because that's what caused, it flipped on the other side and now you're there. Good point. What about this? Person has acute renal failure. What acid-base disorder? Acute renal failure. What acid-base disorder? Why metabolic acidosis? Why? You're right, but why? Is it lung? No. Is it vomiting or suctioning? So it's got to be metabolic acidosis, because everything that isn't lung or vomiting or suctioning is metabolic acidosis. So what about infantile diarrhea? What acid-base disorder? Metabolic acidosis. Why? It's not lung and it's not vomiting. That's the other end. Diarrhea. Okay. What about third-degree burns over 60% of the body? Third-degree burns over 60% of the body, first phase. What? Absolutely, metabolic acidosis, because it's not what? Lung, and it's not vomiting or suctioning. Okay, what acid-base disorder do you see with idiopathic bullous pemphigus? What? Yeah, metabolic acidosis. Very good. Absolutely correct. Why? I mean, I don't know what it is.
It is long, though.
But if it is long, it's, I mean, you know, it's only, you got one body system out of 13. Right? And if it's vomiting or suction, you've got 1 out of 1,000 symptoms. So when you don't know what it is, what's your answer? Absolutely. Metabolic acidosis. In everybody right now. Right now, as you're sitting there, I want you to set your default setting for answering acid-base questions to metabolic acidosis. Okay, everybody, do it. Okay? Do it. So that when you, what do I never want to hear? I never want to hear you guys go, oh, I don't know what acid-base disorder is because I've never heard of that disease. That's when you absolutely do know what it is. It's what? Metabolic acidosis. I've used that rule for 20 years. I take the Hesse twice a year. I take ATIs. I take Kaplan junk. No, stop. I shouldn't say junk. Why did I say that? Kaplan quality materials. And I do every book that's published, everything that's there. I do that. Why do I do it? It's my job to prepare for you guys. You know, I better know what's out there, and I better know what's current, and I better know how it's being tested. So I've done, if it's been published, I've done it. I've even been to the NCSBN site and done their questions. So I know what these questions, and every time I don't know on an acid-based question, what does Mark Klimek pick?
Metabolic acidosis.
And he's 100% right every single time. I have never missed a question using that. All right? So let me ask you this. What do you have to know for acid-base? Well, what you have to know is if the pH and the bicarb are both in the same direction, it's metabolic. As the pH goes, so goes my patient, except for potassium. Matt Kuzmal. Overventilate, underventilate, translate. Vomiting or suction, metabolic alkalosis. Everything else, metabolic acidosis. If I don't know what to pick, metabolic acidosis. That's acid-base. That's all you have to know. So, say it with me. If the, come on, get in. Okay, if the pH and the bicarb are both in the same direction, it's metabolic. As the pH goes, so goes my patient, except for potassium. Who's your favorite Scotsman? Okay. Overventilate, underventilate, translate. What do I mean by that? Overventilate, underventilate, translate. Yeah, translate the word. Overventilate is respiratory alkalosis. Underventilate is respiratory acidosis. If it's vomiting or suctioning, pick metabolic alkalosis. For everything else, pick metabolic acidosis. And when you don't know what to pick, pick
Metabolic acidosis.
Yeah, I use that all the time. That works for you. Okay, those are helpful tools that work. All right. Yes.
So this one, just to make this clear, that one question you asked, if you have severe vomiting and you've gotten dehydrated now, that you look at the dehydration.
Right.
So now it's
right. There's a rule in test taking.
So watch what they're asking.
Yeah. When you want to get a question right, you always pay more attention to the modifying phrase than the original noun. Did everybody hear that? You always pay more attention to the modifying phrase than the original noun. Do you see what I'm saying? So a person with obsessive compulsive disorder who is now psychotic, what's more important? Psychotic than obsessive. Do you see what I'm saying? A patient with vomiting who is now dehydrated. The dehydrated takes precedence over. So the modifying phrase trumps original noun. And people get caught on that every time. Boku questions. They crash and burn on that. Because they're focusing on original noun. It's gone past original noun. It's now modifying phrase is what the question's about. Good question. Okay, let's talk about ventilators and we'll take a break. Ventilators. The first two things you have to know is the alarms. You have to know the alarm systems. And you have to know how the blood gases articulate with ventilators. There is a thing called a high pressure alarm. A high pressure alarm is triggered by increased resistance to airflow. Increased resistance to airflow. In other words, the machine is having to push too hard to get the air into the lungs. It's having to push too hard. There's resistance. And when that happens, the machine will set off a high pressure alarm. Because you understand, when you set up a vent, you set up two alarms. You say, I don't want you to use less than this pressure to get that air in, and I don't want you to use any more than that pressure. You tell it that. And then when it exceeds that, the high pressure alarm goes off. Say if you set the high pressure at 40 millimeters of mercury, and you say, I don't want you to push, machine, I don't want you to push any more than 40 millimeters of mercury to get that air in. If the machine has to, it will set off the high pressure alarm because it's telling you it's too hard. I'm having to work too hard because it's high pressure. Does everybody understand that conceptually? Okay, now what would it be due to? Well, obstructions. There are 3 obstructions. Number 1, kinks in the tubing. The tubing could be kinked. Would that increase resistance? Mm-hmm. Sure. So what do you do for that? That's rocket science. Unkink. Okay. Then, second most common obstruction is water condensing within the tube. There's water condensing in the dependent loops. So what do you do for that? Now there are more rocket science here. Empty it. And the third most common cause is mucus secretions in the airway. They've got goop there. Gunk. Junk. Mucus. And what do you do for that? Now what will be... Suction is correct, but what would you do before you suction? And I'm not talking about pre-oxygenating them, because that is true. But is there another strategy that would be done to mobilize secretions before you would actually suction the person? What would you do? Yeah, change position, turn, cough, deep, breathe. Change position, turn, cough, deep, breathe. So you would do that first, and if that didn't work, what would you do? Suction. What do you guys know about suctioning airways? What do you think? Good, bad, otherwise? What do you think? Give me your impression. The more you do it, the more secretions, problems you cause. So it's a double-edged sword. So how often do you suction patients? Every 15 minutes, every hour, every 2 hours, every 4 hours, or none of the above? None of the above. How often do you suction people? As necessary. And that means when they cannot mobilize it after they've been turned and coughed and deep breathed. In ICU, I'm notorious for getting... Nurses always negatively talk about me in ICUs because I don't do much suctioning, but I do an awful lot of turning. And I find if somebody's O2 sat's low and they're tacking and they're looking like they need, and I don't get good air exchange and the high pressure alarms are going off all the time, I turn them. Patient coughs and whack, out comes this thing, hits the wall on the other side, and then they pink up and they're just fine, thank you, and I never did suction them. And I'll go and report and they'll say, how many times did you suction him? Oh, I didn't suction him at all. How come you never suction people? Well, his O2 sat is 98 on room air. You got a problem with this? You see what I'm saying? His lungs are clear. He's got 98 on room air. Temperature's normal. You got a problem? Okay? So I do a lot of turning, man. I do a lot of turning and coughing and deep breathing, and I find I don't have to do a whole lot of suction. Some people, yeah, but not as much. Okay, so that would be a click and drag. What do I mean by a click and drag? Order. What would you do first? High pressure alarm goes off. What do you do first? What do you click first? Unkink. Check for kinks and unkink. Click it, drag it, drop it. Then what would you grab second? Empty water out of tubing. Click, drag, drop. Then what? Turn, cough, deep, breathe. Click, drag, drop. Then what? Suction, click, drag, drop. That would be your order. Turn the page and let's talk about low pressure alarms. What's this saying? Decreased resistance. Remember I told you always set a low level, and if it is below that, there's decreased resistance. So what's the machine saying? Yeah, that was too easy. Yeah, I had to work too little. That was way too easy, pushing that breath in. Well, what do you think would cause a low pressure alarm? Decreased resistance. Disconnections. There are 2 disconnections you need to know about. The first one is disconnection of the main tubing. If the main tubing is disconnected, what do you do? Yeah, it's more rocket science. Reconnect. The other most common disconnection is the oxygen sensor tubing. What is the oxygen sensor tubing? What is that? Anybody know?
Senses the level.
It senses the FiO2 right at the trach area or the airway area. Well, what's it look like? Anybody know what it is? It comes from the ventilator machine. It's a wire, a black coated wire. It's very small. It's probably about half the diameter of your pencil or pen that you're using there. And it goes right along the tubing, piggybacking it, along the tubing, and it comes right where the trach or the endotube is, and it kind of just hooks. It's like a. Do you have a computer where when your battery's low, you take the cord and you hook that little cord in there, makes a right angle? You have one like that? Well, it's like that. It hooks into that hole in the tubing, and it measures the FiO2, the oxygen delivered right there. But if that pops off, when the air comes in, what's it do? It goes out that tube instead of into them, and there's less resistance. Do you see how that would work? So you have to just take that sensor and plug it back in. Because so many nurses, it'll be going bong, 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 low pressure, and they're going, but it's connected, and here's the wire hanging down, and they don't see it. So reconnect the main tubing, then reconnect the oxygen sensor. Those are the two most common problems. So in general, what are high pressure alarms due to? In general, obstructions. In general, what are low pressure alarms due to? Disconnections. And LPNs, this is the same as RNs. You understand the RN test to LPN is the same information. It's just from a different perspective. For example, like an RN question would say, you have the following 4 patients. Which one would you assign to an LPN? The LPN question would say that you have the following 4 patients. Which one would you accept as an assignment from an RN? It's the exact same 4 people, just looking at it the other way. Do you see what I'm saying? So you really do, LPNs and RNs need to know basically the same kinds of things. They just need to know the difference in the scope of their practice. In some ways, no, I won't go there. Okay. What about acid-base disorders? Respiratory alkalosis. Respiratory alkalosis means the ventilator settings may be too what?
High.
Why did you say that?
Eating too much.
We can turn respiratory alkalosis into another word. What can we turn it into? Respiratory. Ventilate. Alkalosis. Over. So then you read it. Over-ventilating means the ventilator settings may be too high. See how easy it is? All you do is take these acid-base disorders, turn them into just normal words, and the answer will jump off the page at you. So what is the other word for respiratory acidosis? Underventilate. So underventilating means the settings are too low. You got that? Now how would this be applied in a question? And we'll do this question, then go to a break. The doctor says, wean off vent in AM. Got it? He's writing it today for tomorrow. Wean the patient off the ventilator in the morning tomorrow. The 6 a.m. ABGs show respiratory acidosis. What would you do? A, follow the order. B, call respiratory therapy. C, hold the order, call doctor. Or D, begin to decrease the settings. What would you do? Talk to your buddy. And LPNs, it would be wherever it says call doctor, you can put notify RN. What's your answer? C. The answer is C. Why did you know it was C?
Underventilating.
He's underventilating. How do you know he's underventilating? He's got respiratory acidosis. So does he need this ventilator? Oh yeah, he does. Because he's being underventilated on the ventilator. He's on the ventilator and he's already underventilated on the ventilator. Am I going to take him off the ventilator? He's going to be even worse. So what acid-base disorder did you want to see at 6 a.m.? Respiratory alkalosis, which means he's being overventilated. In that case, he probably doesn't need the ventilator. So is this hard or easy? Easy. Do you guys an hour ago, if I told you got to get a bunch of questions on ventilators and acid-base and how you use your acid-base imbalances to know what to do with ventilators, how many would be going, oh my goodness? Okay, how many do you see it's not really hard? It's very simple. Very, very easy. You can be whiz-bangs at this. Why is B a bad answer? Why is B a bad answer? What's that? Yeah, never pick an answer where you don't do something and somebody else has to do something. Because you may feel like doing that, but that isn't the answer. Okay, that's what I call the chicken answer. You know, you're afraid to call, so you have respiratory therapy do it. If a patient says to you, I have cancer, I only have 6 months to live. Do you think there's a heaven or a hell? Where do you think I'll go when I die? What would you do? Do not pick, call chaplain. Now, you may not feel like you want to deal with that right then and right there, but as a nurse, you're supposed to say what? What do you think about? Do you see what I'm saying? That's the answer. Yeah, you're going to hell. How's it make you feel? Yeah, I can see that. Don't tell anybody at Cedarville I said that. Okay, take a 10-minute break. You guys have been really good. And we'll come back at 25 after. Darker and darker. Okay, alcoholism. Page 4, alcoholism. We're going into some psych and some med-surg both with this one. I want to talk about the psychological aspects of alcoholism, called the psychodynamics. The number one problem in alcoholism psychologically is the same as the number one problem in any and all abusive situations. The number one problem in abuse is denial. Denial. Abusers have an infinite capacity to deny. In fact, an abuser has to deny in order to continue the behavior. Because what does denial allow that abuser to do?
Keep doing it.
Keep doing it without having to answer for it. They just deny they have a problem with it. Now, I want you to understand, the title of this lecture is what? Alcoholism, but this first part is you can use the alcohol rules for any abuse. So what's the number one psychological problem in child abuse? What's the number one psychological problem in gambling? What's the number one psychological problem in cocaine abuse? What's the number one psychological problem in spouse abuse? Elder abuse. Denial is the number one problem in all abusive situations. Why is it number one?
We're not recognizing the problem.
How can you treat someone that denies they have a problem? Right? So until they admit they have a problem, you've got a problem. Okay, definition. A, definition. What's the definition of denial? It is refusal, that goes in the first blank, refusal to accept the reality of a problem. They refuse to accept the reality of it. They say, I'm not an alcoholic. I can quit anytime I want. I'm not a spouse abuser. We just have a really physical relationship. I'm not a child abuser. I'm just a really strict parent and my kids aren't spoiled. Do you see what I'm saying? I'm not a gambler. I like games of chance. I'm not a food abuser. I'm a gourmand. You know, they have all these denials about their problem. So how do you treat denial? Letter B. You treat denial by confronting it. You confront it. Confront. You confront it by pointing out to the person the difference between what they say and what they do. So how you confront someone is this. You say, okay, you say you're not an alcoholic. It's 10 o'clock in the morning, you already drank a 6-pack. You know what I'm saying? You just confront them. What did I point out? The difference between what she said, which was what? I'm not an alcoholic. And what she did, which was drink a six-pack before 10 o'clock in the morning. You say you're not a spouse abuser, but she has a restraining order against you. You see the confrontation? You say you're not a child abuser, but Protective Services has your children. You see, you say you're not a food abuser, but you're 400 pounds and you're 5'1". Do you see what I'm saying? It's my thyroid. Okay, it's your thyroid. All right? But the point is that they will deny what they have, and you confront it by pointing out the difference between what they say and what they do. That's confrontation. Now, don't get thinking that confrontation is the same as aggression. Don't get those two things mixed up, because aggression attacks the person. And aggression says, you are too an alcoholic, you jerk, you have to admit it. Do you see, what did I attack? What did I attack? Her. You, jerk, admit it. When I confronted, did I attack her?
No.
You what? Say you're not an alcoholic. That's sort of, okay, you say you're not an alcoholic. Did I attack you?
No.
No, I just said you say you're not an alcoholic, but it's six-pack gone by 10. I mean, you're just saying, hey. You're not saying right, wrong, good, bad, horrible, wonderful. You're just saying, hey, this is what it is. This is what I see. You confront. So don't get confrontation mixed up with aggression. Aggression attacks the person. Confrontation attacks the problem. On boards, never attack a person. Just another little note. They have these questions where you're interacting with staff, and they'll say something like, you're dealing with a staff nurse that has more seniority than you on your first job, and they just find fault with everything you do. You understand the scenario? Well, how do you handle that? What do you say? Does anybody know what you say? What's bad to say? And think about pronouns. What pronouns would bad answers have, and what pronouns would good answers have in that scenario? You versus I. So explain that to me. What do you mean? What's the good, what's the bad? The good answer has what in it? I. Bad answer has you. So what don't you say there? Why don't you like me? Why are you so mean? The right answer is, I seem to be having I seem to be frustrating you. I seem to be having a problem, or or seeming to not get along well. You see what I'm saying? Always, when you're dealing with psychodynamic problems with staff, use the I. I'm, not you. Do you understand that? That's a real big thing they are testing a lot now. Okay, same thing with physicians. Physicians, when you question them on the phone, don't say, you wrote the order incorrectly. You say, I'm having a difficult time interpreting exactly what you want. Do you see the difference? Okay, so when they are in denial, what do? Confront. Deny, confront. Deny, I want you to link that in your mind. Deny, they deny, you confront. They deny, you confront. However, be careful, because there's another place where denial is operative, and that is loss and grief. Don't people go through denial and loss and grief? Have you heard of the stages of death and dying, loss and grief?
Yeah.
What are they?
DABDA.
DABDA. D-A-B-D-A. D-A-B-D-A. Denial, anger, bargaining, acceptance, depression, acceptance. Denial, anger, bargaining, there's your DAB. And depression, acceptance, there's your DA. DABDA. So, denial is an accepted, healthy, normal first reaction to grief and loss. So what do you do for the denial of loss and grief? Do you confront it? What do? Support it. The word is support. You want to support it. So my point is this. When you get a patient in denial, what do you have to pay attention to get the question correct? Is it loss or abuse? Is it loss or abuse? With abuse, you what? Confront. With loss, you support. I live in Cedarville. It's college of 3,000 in a town of 3,000. So So there's one student for every person in the town. But we were basically a farming community with a college, and we have a lot of one-handed men in our town. Why? Baler accidents. The balers amputate their hand. So we have a lot of farm machinery, one-handed baler accident guys. Can you imagine a farmer comes in, his hand gets amputated, and it's all wrapped in a bandage. The next morning, you're taking care of him, and he says, I can't wait to go home and play piano. Problem. He only has one hand, right? So he's in what? What is he refusing to accept? The reality. Is that denial, refusing to accept the reality?
Yes.
So he's in denial. What would you never say to him? You say you're going to play piano, but you only have one hand. That's called what? Confrontation. Now, is confrontation okay for denial? Yes, as long as it's abuse, but not if it's loss. And this guy is lost. So what do? You say, oh, well, how long have you played piano? What's your favorite kind of music? Did you take lessons? What are you allowing that denial to continue? You're supporting it because it serves a function. Is everybody getting the difference? But if you got an alcoholic says, oh, I'm not an alcoholic. I can quit any time I want. He's in what? What's the strategy? Confront. What would be really horrible to do? Support. You wouldn't say, oh, how long you been drinking? What's your favorite beverage? Did you take lessons? Did you ever go to have that, hurricane over there at, MacGyver's bar? You don't support it. So you see where you got two totally different answers for denial. Just pay attention to that. Okay, let's talk about the number 2 psychological problem that abusers have, and that is dependency, codependency. Dependency is when the abuser gets the significant other to do things for them or make decisions for them. In other words, the abuser says, oh, would you call my boss? Would you go do this? Would you do that? And they do it. So who is dependent? The significant other or the abuser? The abuser is dependent. Okay. Now, codependency, on the other hand, is when the significant other derives positive self-esteem from making decisions for or doing things for whom? The abuser. So the abuser says, call my boss, tell him I'm sick. That's an example of what? Dependency. The significant other calls the boss, says, he's sick, he can't come to work. Hangs up, says, oh, aren't I a wonderful spouse? Because I did that, because I don't know anybody else that would do it for that jerk. What are they? How do you know they're codependent? Did they get positive self-esteem? Yeah, what did they say? Oh, aren't I a wonderful spouse because I did that? See, they have this rather pathologic yet symbiotic relationship. One is dependent, the other gets positive self-esteem from meeting those dependency needs, and they just feed off the other. What does the abuser get out of the relationship? What does the abuser get out of the relationship? What's that?
Kids keep doing.
Yeah, a life without responsibilities. He gets to keep doing whatever he wants, abusing. What does the significant other get out of it?
They feel good. They feel
positive self-esteem out of it. And then we sit there and we say what to the significant other? Leave him. What are you doing in that relationship? Get out of it. Right? But they can't get out of it because what's tied up in that whole thing? Their self-esteem. So, it's really kind of tough to treat. Well, then how do you treat it? How do you treat it? Well, number 1, you set limits and enforce it. You set limits and enforce them. That goes fill in the blank. Set limits and enforce them. In other words, you start teaching the significant other to say the 2-letter word, no. And then they have to keep doing it. Will you call my boss? No. Would you go buy me some? No. Would you drop me off at the track? No. Would you get me a ham sandwich out of the refrigerator? Well, see, that would be okay. I'm not saying say no to everything. I'm saying say no to those things where you're feeding into everything, all right? But that's not good enough. That alone will not work. Because you must work on the self-esteem of the codependent person, or it will never work. Because as soon as the codependent starts saying no, what will the dependent abuser start saying? You don't love me anymore. You're a mean, nasty old whatever, because you are just horrible. You're horrible. And what's that person playing right at? Self-esteem. They know what side the bread's buttered on. And they go right at that person's self-esteem, and within 10 minutes they got them emotionally manipulated right back into the whole system. So in order for this to work, what does the codependent person have to say? I'm saying no, and I'm sticking to it because I'm a good person because I'm saying no. Oh, you're nasty. I don't care what you say. I'm a good person. And that's how you have to work on it. The thing is, I worked at Lafayette Clinic in Detroit, Michigan for a couple of years, and it's mostly alcohol rehab and seizure. And we found that when we treated codependency, dependency successfully, when we treated this problem, guess what we lost? The relationship. You know, the codependent person would go, I'm a good person, I don't need you, and why am I here? And they'd leave. So, you know, we'd solve the problem but lose the relationship. Real common. Okay, turn the page. Let's talk about manipulation. What's the definition of manipulation? It's when the abuser gets the significant other to do things for him or her that are not in the best interest of the significant other. The nature of the act is dangerous or harmful. What goes in the blanks is interest and harmful. Interest and harmful. So how is this like dependency? How is manipulation like dependency? Yeah, in both situations, the abuser is getting the other person to do something for them. Then how in the world do you tell the difference between those two things? What's that? Well, neutral versus negative. Look at what they're being asked to do. If what the significant other is being asked to do is neutral, no big deal, no harm done, no harm, no foul, it's simply dependency, codependency. If what the significant other is being asked to do is inherently harmful or dangerous to the significant other, that person is being manipulated. So let me give you two examples, and you tell me which one is denial, which one is dependency, and which one is manipulation. A 49-year-old alcoholic gets her 17-year-old daughter to go to the store and buy alcohol for her. That is what? Why?
This is an alcoholic.
Well, no, because a 17-year-old going and buying alcohol is illegal in the state of Ohio. So it is illegal. So she's being asked to do something illegal. Now, what about this? A 49-year-old alcoholic asks her 50-year-old husband to go to the store and buy alcohol for her. Of what is that an example? Why is it dependent? It's the same thing, buying alcohol.
She's old enough. She knows he has a problem, and she's old enough.
I mean, well, and she's of age. There's nothing. How harmful is it for a 50-year-old man to go to a store and buy alcohol? Any harm? No. So that's simply dependency. But when the 17-year-old goes to buy alcohol, that's illegal. There's harm. That's manipulation. Let me give you an example. Tuesday evening, or last Friday evening. Remember Tuesday, last Friday, around here? Okay. Your neighbor calls you. No, your brother calls you. Sister-in-law calls you and says, "Would you pick up little Billy from basketball practice at school so he can spend the night at your house because of the snow?" Now you have a what's four-wheel drive what? Hummer, Jeep. What's best in the snow? Not ice, but snow. What? Four-wheel drive, some big. Okay, you got a big earth mover, four-wheel drive earth mover. Okay, and you live 3 blocks from the school, and you say, "Okay, sister-in-law, I'll do that." You are being what? She is being dependent on you. You're being codependent because you'll say, "Oh, aren't I a wonderful brother-in-law for doing this?" Right? What if your sister-in-law calls you? She's got the 4-wheel drive all-terrain vehicle, and she lives 3 blocks from school. She asks you to pick up her son and take him to your house. You have a Kia Sophia with bald tires, and it starts every other time. It leaks oil, got no heat. Do you see what I'm saying? And you live 20 miles from the school. And what's happening here? You're being what? Manipulated, because it is inherently dangerous for you to get in that car and go that distance when she could do it easily, safer, better herself. Whereas in the first one, it was safer and better for you to do it than... Do you see what I'm saying? Dependency and manipulation are similar. It's just the only way you tell the difference is one, you're being asked to do something which is bad for you, that's manipulation, versus something that's neutral, that's dependency, codependency. Can you tell the difference now? Okay, good. All right. How do you treat manipulation? You set limits and enforce them. So you start saying what 2-letter word? No. Number 2, it is easier to treat than dependency, codependency, because nobody likes being manipulated. I have never heard a person say, oh, I must be a wonderful person for being manipulated. Do you know what they all say? I must be an idiot for falling for that. Do you hear any positive self-esteem going on? No. So there's no positive self-esteem issue going on with manipulation like there is with dependency, codependency. You see why it's easier to treat? Okay, let's just summarize. How many patients do you have with denial? If Bob is in denial, how many patients do you have? 1, 2, or 3, or 4? Bob is in denial. How many patients do you have? 1, 2, or 3, or 4? 1. Bob is dependent. How many patients do you have? 1 or 2? 2, because you got to get the codependent. Bob is a manipulator. How many patients do you have? 1 or 2? 1. Do you see what I'm saying? Because you don't have to do anything with the person who's being manipulated because there's no self-esteem issues. So with denial, you got 1 patient. With dependency, you have 2 patients. With manipulation, you have 1 patient. Does that make sense? Okay. All right, let's talk now about things specific to alcoholism. Let's talk about Wernicke's or Korsakoff's. Wernicke's and Korsakoff's. Typically, they are separate, but boards often lumps them together. Wernicke's is an encephalopathy and Korsakoff's is a psychosis, but they tend to go together. You find them in the same patient. So Wernicke-Korsakoff's is number 1, psychosis induced by vitamin B1 or thiamine deficiency. This is a scenario where you lose touch with reality. You go insane because you don't have B1.
What's induced?
Psychosis. Psychosis, which means insanity or loss of touch with reality. These are psychotic people, not just a little bit emotionally disturbed. These are psychotics. The primary symptom, number 2, is amnesia with confabulation. Amnesia with confabulation. Amnesia means memory loss. Confabulation means making up stories. Why do they make up stories?
I don't know.
Because they forgot. Well, in that case, then I'm psychotic. Because I often make up details that I have forgotten. Right? So then why are they psychotic and me not? Fair question. Why? So everybody that forgets something and makes up a story to fill in what they forgot is insane, psychotic. True or false? False. Well then, explain to me the difference. Why? Why are these poor people called in psychotic and we're not? Because they believe it. See, when I fill in details because I forgot, I know it's not really true. But they really believe it. The lie is just as real as reality. And their memory loss is not, oh, I forgot what I did last night when I was drunk. No, it is, what happened to the 90s? They don't remember anything in the whole 1990s. They'll lose entire decades of their memory. So what will they do? Make up stories as to what they were doing during the 90s. I had a guy that, with Wernicke's, he was Ronald Reagan's national security advisor during the 80s. The guy had never made it past 3rd grade. Now, whatever you thought of Reagan, he wasn't that bad that he would have had a 3rd grader running the national security. You know what I'm saying? So he definitely was never Reagan's national security advisor. He thought he was. He could tell you meetings, dates, times, people. He had this whole psychotic reality built around Ronald Reagan's terms in office. And he believed it. He literally believed it. He believed it as that was as real as anything that was happening right then and right there. So, how do you deal with that? How do you think you deal with that? You got a Wernicke's-Korsakoff's guy who thinks he is Obama's Secretary of Defense. And so he's got to get up and go to a cabinet meeting right now. How do you deal with that? What would probably be a bad way to deal with that? What's that? Okay, we don't usually agree or disagree.
Confrontation.
We don't confront. Why?
Because they'll get angry.
Why?
Because you're telling them that what they're saying isn't true and they believe it.
Right. And it's due to brain damage. So are they ever going to learn what's true and what's real?
No.
So is this permanent or not? Typically permanent. So you don't present reality because they can't learn it. So what do you do? See, this is the questions they ask you. They give you a person with Wernicke's, and they say that Wernicke says he's going to a presidential cabinet meeting at 8 o'clock this morning. How do you deal with that?
Distract.
Okay, distract is not as good a word as redirect. Redirect is a really good word. And that means to take what he's all about that you can't do and rechannel it into something he can do. So can he go to Barack Obama's cabinet meeting this morning? No. So what you do is you say something like this. Well, why don't you then get a shower? When you're done, we'll go watch CNN to see what the news of the day is in Washington, D.C. You see that? Is he going to do that? Probably, because do you see what I'm saying? And you don't get into a fight with him about, no, you're Joe the milkman, you're not Ronald Reagan's national security advisor. Do you see what I'm saying? Because that's fruitless and pointless. So when somebody has Wernicke's and Korsakoff's and they talk crazy, what do? Redirect. You don't present what? Reality. Because presenting reality is for those people that you think that can learn it, and these people can't learn it. So redirecting them is the way. Now let's talk about characteristics. Number one, it is preventable. You never have to get this in the first place. How can you prevent getting this in the first place? Take vitamin B1. But by the way, vitamin B1 is a coenzyme necessary for the metabolism of alcohol. You don't have to know this. It's necessary for the metabolism of alcohol. So if you don't have B1, you won't metabolize alcohol. It won't go into Krebs cycle. Does that sound familiar? It won't get burned up for energy. So what will it do? Accumulate. And where will it go? Brain, and it will destroy brain cells. That's how this happens. So all they need to protect the brain is to take vitamin B1, and then any alcohol they drink will be what? Metabolized. So they don't have to stop drinking. All they have to do is take their one a day with their vodka in the morning and they'll be fine. They will be perfectly fine. You get a lot of good compliance with this. Okay. B, it is arrestable, which means you can stop it from getting worse. How can you stop it from getting worse? Take B1. Stop drinking? Is stop drinking necessary? No. C, it is irreversible. Now, not everybody has irreversible, but it's about 70% irreversible, so you always say irreversible. Do you understand on boards you always answer with the majority? If something is majority of the time fatal, you say it's what? Fatal. You don't say, well, 5% of the time it's not fatal, so I'm saying it's not fatal. No, don't do that. Go with the majority. So it is irreversible. So it's preventable, it's arrestable, and it's irreversible. 2 good news, 1 bad news. All right, let's turn the page and talk about some drugs that have to do with alcohol. Antabuse or Revia. Antabuse or Revia. Does anybody know the generic name for these drugs? Disulfiram. Disulfiram. Number one, it is aversion therapy. Aversion therapy. It's a form of aversion therapy. Now, what aversion therapy is this. The word aversion means a really strong hatred for something. A gut hatred for something. What we want alcoholics to develop is a gut hatred for alcohol. That's what we're trying to do here. Well, how do we do it? Well, we give them this drug. Now, you don't have to write this down, but just sort of listen to this for a second. When you take this drug and it gets to a blood level in your blood, if you drink alcohol, it will interact with that chemical in your blood and make you super sick to your stomach. Really super sick. Horribly ill. Let me ask you, have you guys ever been to a restaurant and gotten sick afterward from eating at that restaurant? Anybody? Will you eat at that restaurant anymore? Now, if you go, you probably won't order, you may order something else, but you're not going to order what made you sick because you have developed a what? Aversion to that restaurant. Okay, because if I gave you a $20 bill right now and said, go eat at that restaurant and buy that meal, would you do it? No. Would you take my $20? Yeah. You go somewhere else and buy something else, but you wouldn't go there. So I couldn't even pay you to eat there, could I? Well, we want the alcoholic to have that same reaction to alcohol. In other words, we couldn't even pay him to what? Drink. So if you couldn't even pay an alcoholic to drink, I think that's pretty much a cure. Now, the only problem with this drug is it works in theory better than it works in reality. Or else we'd have had a cure for alcoholism years ago. So it really doesn't work as well as they say it does. But you still need to know how it's supposed to work and whatnot. So the thing the boards wants to know is how long does it take to get into their system and how long does it take to get out of their system? In other words, what's the onset and duration of its effectiveness? And that answer is 2 weeks. 2 weeks. So how long do they have to be on the drug before it starts to work?
2 weeks.
And how long do they have to be off the drug before they can safely drink again? 2 weeks. So usually the way it happens is doctor prescribes antabuse. You sort of have to live sort of like a transition, like a recovery place, a transition home, where for 2 weeks they make sure you take the pills, and then you're let out into the community, and it will work. And every time you drink, you'll get deathly ill. So, but if you decide you want to drink at a high school reunion, when do you have to stop taking your antabuse?
2 weeks before.
2 weeks before the reunion, or you're not going to be able to do it. All right, now, number 3, patient teaching. Teach these patients to avoid all forms of alcohol, to avoid nausea, vomiting, and possibly death. Now, death isn't what we're going for. That would cure the problem, but it's not what we're going for. Now, do you suppose you have to teach an alcoholic, hey, let me talk. Let me tell you what has alcohol in it. Whiskey does, wine does, beer does, tequila. They know that. What you have to teach them that they have to avoid is stuff that they wouldn't think that they have to avoid that they do. And number 1, mouthwash. They need to avoid mouthwash. Even if they swish and spit, they're still going to get sick. Number 2, aftershaves. Even if they put it on topically, they're going to get nauseated. Now, they won't get violently ill from that, but it will make them nauseated. Perfumes and colognes should not be used. Same reason. Insect repellents, like mosquito sprays, off deep woods cutter, those are all bad. They'll make you sick. Any over-the-counter that ends in the word elixir, E-L-I-X-I-R. Because what do all elixirs have in them? Alcohol. Dimetapp elixir, Robitussin elixir, Dayquil elixir, NyQuil elixir, Tylenol PM elixir, Benadryl elixir. Alcohol-based hand sanitizers. In Greene County, about 6 months ago, we had our first case of alcohol hand sanitizer poisoning. This alcoholic got into Bob Evans and drank every single bottle of hand sanitizer he could get his hands on to keep the shakes away. Because he knew it had alcohol in it. In fact, I've heard that they've taken it out of the prison systems because guys are learning how to distill it and sell it. Another thing they're not allowed to have is uncooked icings. Remember those uncooked, those no-bake icings that you make? Because what do no-bake icings have in it? Vanilla extract, which is powerful. That's Granny's way of getting.
Wow. I didn't know.
All right, and remember this one. Here's the one that everybody gets suckered in on. Do not pick the red wine vinaigrette. They can have the red wine. Why are they trying to sucker you in on there? Wine. Do you see what I'm saying? And you go, oh, wine. They can have red wine vinaigrette. They just can't have the cupcake with the unbaked icing on it. Okay. Okay, is that all the blanks filled in there, guys? Okay. Now let's talk about overdoses and withdrawals. Bad news. You got to know all your drugs, all the overdoses, and all the withdrawals. Good news. You only have to answer 2 questions to get them all correct. It's an easy way of knowing it. So here we go. Every abused drug, did I say every drug? Every abused drug is either an upper or a downer. Would you agree with that?
Yes.
Why are drugs that are not uppers nor downers, why are they not abused?
Because it doesn't.
They don't do anything. Right? Although there is an exception. What is the #1 most abused class of drug that's not an upper or a downer?
Nicotine.
Laxatives in the elderly. The elderly abuse laxatives. But that isn't upper or downer. That's inner or outer, I guess. I don't know. But every abused drug is an upper or a downer. Correct? Okay. Have you ever had anybody come up to you on the street and say, hey, want to buy some Nexium? They're not selling that on the street. Because it's not an upper or a downer. So, letter A. Do you see in the box, letter A? When you get an overdose or withdrawal question, what's the very first question out of your mouth? Is the drug an upper or a downer? That's the very first thing you must establish. That is the first step you take in getting the question correct. Now, let's talk about uppers versus downers. The names of the uppers are caffeine, cocaine, PCP/LSD. What are those? PCP/LSD, what are those called? Psychedelic hallucinogens. Sounds like up to me. And then another class are the methamphetamines. METH amphetamines. Methamphetamines. Crystal meth, all that stuff that you buy at the grocery. You know, you buy the Sudafed, all the decongestants, and you cook it down. That's the upper meth. New that you're going to have to know is Adderall, which is the ADD drug, the attention deficit drug. And a lot of kids with ADD are selling their Adderall to their friends at school rather than taking it. ADD is the first 3 letters of Adderall. Okay. But that's another upper, and that's going to be tested probably starting April 1. It's going to be a new one. Now, that's only 5 drugs: caffeine, cocaine, PCP/LSD, methamphetamines, and Adderall. Those are uppers. Well, what do you think the signs and symptoms are when you're on an upper? Things go up because you're on an upper. Figure that out. You know, uppers make you go up. You know, that's pretty hard to remember. So what are they going to have? Give me some signs and symptoms. Principles.
Euphoria.
Euphoria. Tachycardia. Restlessness. Irritability. Bowels. What are you going to? What's the bowel status going to be? Borborygmi, diarrhea. What are the reflexes going to be? What numbers? 3 and 4. Flaccid or spastic? Spastic. Are they going to respiratorily arrest or seize? Should you have a suction machine or an ambu bag? Are you getting this idea? Uppers make things go up because they are uppers. All right? Downers. What are the names of the downers? Am I going to memorize anything? No. Why? Everything that's not an upper is a, because every abused drug is either an
Upper.
or a.
Down.
There's no such thing as a tweener, so you can't get that. Now, if they want a tweener effect, what do they take? An upper and a downer together, but there's no one drug that gives you a tween effect. Now, there are how many uppers? 5. You know how many downers there are? 135. You know, Dilaudid, MS-Contin, morphine sulfate, codeine, Demerol, fentanyl, Wabane, Nubane, Thorazine, Stelazine, Fluphenazine, Piperazine, Chlorpromazine, Prolixin, Ativan, Xanax, Valium, Librium, phenobarbital, pentobarbital, secabarbital, heroin, hashish, marijuana, alcohol. Do you know what I mean? It's all what? Downers, because it's not an upper. So only memorize. I hate lists, right? But if we can memorize a short one and know everything else is a, that seems like some payoff for me. So what do downers make you do? Go what direction? Because they are downers. So what are you going to see there? Lethargic. Everything that we said, just flip it. And what's going to be the big danger?
Respiratory depression.
Respiratory
Depression.
arrest. Depression and leading to arrest. What do you think about this? Your patient is high on heroin. No, high on cocaine. What's critically important to assess? And one of the answers is B, which says making sure that the respiratory rate is above 12. What do you think? He's high on cocaine. Is a critical measurement making sure that the respiratory rate is above 12?
No.
No, why?
It's going to be high.
There's no way he's going to even be close to 12. You got the wrong patient, but they're trying to sucker you into thinking, oh, respiratory rate. No, you know what I mean? Yeah, respiratory rate's important, but not in this patient, because this patient wouldn't have a respiratory arrest because they're high on an upper, which makes everything go up. You'd rather check their reflexes. Do you see what I'm saying? And we go, oh, ABCs. Could you hear that? Airway, oh, respiratory rate less than 12. Like, ABCs is not a great rule, guys. If you've been living by ABCs, you've been shortchanged for a very long time. It's a very poor rule. I will show you better rules than ABCs. ABCs is a vast oversimplification. How many have used ABCs to get answers? How many have used ABCs? How many have gotten about as many right using it as you get wrong using it? How many you get quite a bit wrong using it? How many get it all right when you use it? Are you understand? How many would say ABCs doesn't really work that well for me? It doesn't. It shouldn't, because it doesn't. Okay. It's a vast oversimplification, but we'll get to that later. All right, B. You see where we're at? B. After you know whether the drug is an upper or a downer, the second thing you ask yourself is, are they talking about overdose or withdrawal? Because they're opposites, and you got to know which one you're talking about. You have to pay attention. Is the question talking about overdose, which is too much, or withdrawal, which is not enough? If you don't pay attention to that, you will miss the question. So what's the first thing you have to pay attention to in a drug overdose question? Is the drug an up or a down? Or what's the second thing you have to pay attention to? Overdose or withdrawal. Once you do those, you've got your answer. Your answer is so simple, it's pathetic. Let's look how it works. Under letter B, do you see where it says overdose or intoxication? Do you see that? You have what? Too much. Now, put it together. Put the answers to the two questions you asked together, and you get your answer for the question. In other words, if they say overdosed on an upper, you have too much what? Upper, and everything goes up. So you're going to pick those up things because you have too much upper. But what if they say downer and intoxication? In that case, you have too much downer, which makes everything go down, and it's going to go the opposite of what the other one did. Do you see the point here? However, what if they talk about withdrawal? In withdrawal, you don't have enough. You have too little. Well, let's put it together. If you have withdrawal, downer, you don't have enough downer. If you don't have enough downer, everything goes... No, okay, I'm doing it backwards. Yeah, on your page it says you don't have enough upper, right?
Too little.
So too little upper makes everything go down, and then too little downer, or not enough downer, makes everything go up. Does everybody see the logic in that? So upper overdose looks like what other situation? Upper overdose looks like what other? Downer withdrawal. And downer overdose looks like upper withdrawal. So in what two situations would respiratory depression and arrest be your highest priority? In which two situations would respiratory arrest and depression be your highest priority? Downer, overdose, and upper withdrawal. Exactly. Which two would seizure be your biggest risk? Upper overdose and downer withdrawal. Do you see what I'm talking about? So what's the first question you ask yourself? Up or down. Second question, overdose or withdrawal. Too much or not enough? Put it together. Just pick the obvious answer. Let me show you how I want you to work this. Squad calls you and says they're bringing in a patient. They're 10 minutes out. He's an overdose on cocaine. What would you expect to see? Select all that apply. Person's overdosed on cocaine. It's coming into your ED. What would you expect to see? Select all that apply. What's your first question? Up or down? The answer is upper. Second question. Overdose or withdrawal. In this case, you have what? Which is putting two and two together. Too much upper, right? So, answer your question. And remember, this is a central nervous system drug, not an autonomic. Talk to your buddy. See what they say.
Yeah, but wouldn't it reflexes deal with the spinal cord?
I
Yeah, they still do.
They deal with the spinal things.
Yeah. Still seeing it. What do you say, Borgavon was?
Borgavon?
So that was on.
It's hyperactive reflex.
Okay, how many
Hyperactive
did you
bowel cells.
select?
4.
You should have selected 4. Okay? So, first task, cocaine is in.
Upper.
Overdose means too much. You got too much upper, everything's going to go what direction? So draw your arrow up, then go hunt. What about irritability? Plus 4 reflexes? Respiration less than 12?
No.
Difficult to arouse?
No.
Or bring me?
Yes.
Increased temp?
Yes.
You're correct. Those 4. You're caring for a client who's withdrawing from cocaine. What are you going to answer? The opposite.
Yeah.
Now you're going to pick respirations under 12 and difficult to arouse. They start doing that on you, you start moving. They need some Narcan. Okay. Are you seeing the idea? So do you have to memorize all these drugs? No. Turn the page. Let's talk about drug abuse in the newborn, or drug addiction in the newborn. This is a real hot topic because we have a lot of babies born nowadays to addicted moms. Always assume, here's the blanks, always assume intoxication, not withdrawal at birth. Always assume intoxication, not withdrawal at birth. So if they say you have a baby at birth or in the first 24 hours, what would you assume the baby is in? Intoxicated. After 24 hours after birth, you'd assume he's in what? Withdrawal. So how old does the baby have to be before you go withdrawal? 24 hours. Now how do you work this? Well, what about this question? You're caring for an infant born to a Quaalude, that dates me. Addicted mom. Nobody uses ludes anymore. A Quaalude addicted mom. 24 hours after birth, select all that apply. Okay, so you got a Quaalude addicted mom. You're caring for this infant 24 hours after the baby's been born. Select all that apply. Difficult to console, low core body temp, exaggerated startle, reflex, respiratory, depression, and seizure risk. Talk to your buddy.
So that's going to
Quaalude's
be
down, right?
up. Body temperature down. Saturated. Startle reflexes. Down.
Why'd you say start reflex? Why'd you say start reflex? Oh, okay.
So that's a downer. And you're in withdrawal.
Many things that go down.
Low temperature and respiratory depression.
That last one says shrill, high-pitched cry. How many did you select?
2. Only got 2.
You should have selected 3. Okay, so Quaaludes, what are they?
Downer.
How do you know they're downers?
They're not
It's not on the upper list. It's not caffeine, not cocaine, not PCP-LSD or Adderall or methamphetamines. You don't know what it, how many didn't know what it was? What should you have said? Downer. When you don't know what it is, pick downer. You got a 100 to 1 chance of being right. I mean, 99 in 100 chance of being right. So you would say this is a downer, and the baby is what?
Withdrawal.
Withdrawing. This has been 24 hours, so he's starting into withdrawal. So he doesn't have enough downer, so everything's going to go up. So, difficult to consult. Yes, oh, hey, there is 4. I'm sorry, I blew it. There's 1. Okay, low core body temp. No. Exaggerated startle. Yes. Respiratory depression. No. Seizure risk. Shrill high-pitched cry. Yes, I'm sorry, I didn't. I wasn't thinking. Now, how many of you are really good at Quaalude newborn situations? How many thought you were? Do you see what I'm saying? It's not that hard. In fact, boards doesn't really expect you to know this. They just want to see if you know some what? Principles that central nervous system depressants 24 hours after birth make the baby go the opposite way. Does that make sense? And they'll pick these things and you're going, oh, I don't know Quaaludes. Oh, I don't know Quaaludes. Oh, I don't know what Quaaludes. Shut up and answer the question. If you don't know Quaaludes, you should know the answer. It's a downer. And then go with it. Because that's what the good test takers are doing. They're putting their money on the best bets. And that ain't the Colts. Okay, alcohol withdrawal syndrome versus delirium tremens. Alcohol withdrawal syndrome versus delirium tremens. You have to know the differences between them. They're not the same. Sometimes people think DTs, delirium tremens, is alcohol withdrawal syndrome. No, they're totally different things. When board says alcohol withdrawal, they mean you're withdrawing from alcohol. When they say delirium tremens, you're in delirium tremens. They are very different. Do not think they're the same. Letter A. Every alcoholic goes through alcohol withdrawal. They all do 24 hours after they stop drinking. So when an alcoholic stops drinking alcohol, within 24 hours, they will all go into withdrawal syndrome. Every single one of them. However, only a minority get delirium tremens. You don't have to know the percentage. It's under 20%. By the way, when do you go into delirium tremens after you stop drinking? Do you know what time frame? 72 hours. So what always comes first? Alcohol withdrawal within 24. Then a couple of days after that, you go into DTs. Here's a statement. You do not have to write this down, but if you understand this statement, then you're good to go. You understand what I said. Alcohol withdrawal syndrome always precedes delirium tremens. However, delirium tremens does not always follow alcohol withdrawal syndrome. You got that? Okay. So if you have DTs, you had what?
Alcohol withdrawal.
But just because you have alcohol withdrawal doesn't mean you're going to get DTs.
What was the second part of that? The alcohol withdrawal syndrome always
Precedes delirium tremens, but delirium tremens does not always follow alcohol withdrawal syndrome. Okay, next difference, letter B. AWS. AWS is the abbreviation I'm using for alcohol withdrawal syndrome. AWS is not life-threatening. DTs can kill you. C. Patients with AWS are not a danger to self or others. Patients with DTs are dangerous to self and others. The word "are" goes in there. A-R-E. They are dangerous. So here are two really big differences. AWS, it won't hurt anybody. It won't hurt you. You're stable. You're fine. DTs, you're unstable. You could die. Second big difference. AWS, they are not going to hurt anybody. Yeah, they're loud and obnoxious because they're withdrawing from a downer, which makes everything go up. They're going to be loud and obnoxious, yeah, but they're not going to hurt anybody. But a DTers, you have to assume is dangerous because they are dangerous. All right, now, Those differences will translate into differences in care, which we will outline in the table below. Let's fill in this table about the differences between AWS and delirium tremens. First column, first row. Does everybody know what box I'm in? First column, first row, under AWS. Regular diet. Next box down. Same column, first column, second row. Semi-private anywhere. Semi-private anywhere. Which means they can be in a semi-private room anywhere on the unit. Same column, third row down. We're just going down that first column. Up ad lib. Up ad lib, which means they can go around anywhere they want to go. And last box in that column, no restraints. You do not restrain these people because they are not a danger to self or others. Now let's compare and contrast that with the DT's client, delirium tremens. Second column, middle column, first box, first row. NPO, clear liquids. NPO or clear liquids. Why? Why seizure? Why up? Yeah, because we're drawing from a downer, everything's going to go up, and the big up is seizure. And with seizure, you get aspiration, so you want an NPO or clear liquids.
Or, you said?
Yeah. On boards, sometimes they'll say NPO, sometimes they'll say clear liquids. They won't have them against each other because that would be too tough to pick, but it'd be either one. The second box down, private near nurse's station. Private room near nurse's station. Why? They're dangerous and they're unstable. See, could you put an alcohol withdrawal patient on a pediatric overflow unit? Sure. They'll be known as Uncle Wally, but and he'll be everybody's best friend, and the parents will say, but he won't hurt anybody. But in DTers, you got to watch these DTers. In fact, DTers probably should be in ICU. Why?
Because they're dangerous and unstable.
Dangerous and unstable. But no self-respecting head nurse of ICU will allow them through the doors. Why? Because they're screaming and yelling like banshees, and they don't want that destabilizing the rest of their population. So they usually get stuck on step-down units. But if you, as an LPN, would you accept the assignment of a DT's client? No, because they're unstable. As an RN, would you accept the assignment? Yes, but what would you have to do with the rest of your assignment if you accept DTers on med-surg? Decrease your workload. Somebody else may have to take 7 while you take 3. Okay? And remember, it's a perfect world on boards. Everybody will be fine with that. The other nurses will think they'll be fine with that. Yeah, I'll take 9, you take 2. It's fine. So what kind of reasoning is really a kiss of death on boards? What line of reasoning? What kind of thought process that you would do in answers which would really be bad? Saying, oh, I wouldn't do that because what? I don't have enough staff. I don't have enough experience. I don't have enough time. I don't have enough money. We don't have enough resources. No. On boards you have what? A perfect world. You have all the money, all the time, all the staff. Everybody's cooperative. Everybody's happy. Everybody wants to make it happen. They even don't mind their assignment being changed every hour. Okay? Okay, let's talk about the next thing down. They are on restricted bed rest, which means no bathroom privileges. If they have to use the facilities, we have bedpans and urinals for them. And lastly, they must be restrained. Why must they be restrained? Because they are dangerous. Now, with what would you restrain them? Certain types of restraints are futile and not used. Some are appropriate. What would be some that would be appropriate and some that would not? Do you know?
Rest restraint.
What about soft wrists? Yes or no?
Yes.
No, they'll get out of that. That's not enough. That's not safe enough. What about 4-point softs? No, that's not. They can get out of that. They need to be in a vest or 2-point locked leathers. Now, what does 2-point mean? 2 extremities. Which 2 extremities? No, not 2 arms. An arm and a leg. Which arm, which leg? Opposite. You always lock down one arm and the opposite leg in 2-point. That's what it means. That's what you're supposed to do. Now, you rotate that every 2 hours, so what do you do 2 hours later? You switch it. Now, what would you do first? Their right arm's locked down, their left leg's locked down. What would you do first? Lock the left arm, then the right leg, then release the... Yeah, don't release them first. You'll only make that mistake one time. And then you'll go, oh, okay, I got it now. You'll remember. Now, what do they both get? Well, they both get an antihypertensive, a blood pressure pill. Why would they get an antihypertensive? Why?
Because everything's going up.
Why is everything going up?
They're on drop.
Perfect. You guys are so excellent. 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 You got it. You're getting it. Okay, they're both on a tranquilizer. Why do they both get a tranquilizer? Because they're up. And why are they up? Because they were drawing from a downer. And they both get a multivitamin containing B1. Why? Wernicke's and Korsakoff's to prevent that. I always say, no B1, you B1. One of those crazies. You know, no B1, you'll B1. And then that last box I shaded. And I shaded that so that you obsessive compulsives, 2 weeks from now, when you go over this lecture, there was nothing you missed. You don't need to call everybody in the class and find out what was in that last box, what was in that last box. Nothing goes in that last box. Okay? All right, let's talk about some drugs, and then we'll take another break. Drugs. Aminoglycosides. This is a powerful, powerful class of antibiotics. As far as antibiotics go, they're the big guns. You know what I'm talking about? When nothing else works, pull out your aminoglycoside, you know? It's like the aminoglycosides are to infections like that scene in Indiana Jones when the big Arab guy comes out with a scimitar, you know, and he starts like this, and Jones pulls out a gun and shoots him. Well, they're like the gun. You know, they're going to blow it away. But you don't use it unless what? Nothing else works. These are dangerous. Now, boards loves to test these. Why does boards love to test these drugs? Because they're dangerous, and this is a test of safety. And do you know these drugs? They're in the top, from my experience, these show up probably in the top 5 most commonly tested groups of drugs on boards. You don't have to know this because I'll repeat it several times, but probably the most common group of drugs you have to know for boards are your psych drugs, and we'll get that on Sunday. The second most common are the insulins, which we'll talk about tomorrow. The third most common are the anticoagulants, which we'll talk about tomorrow. The fourth is digitalis, which we'll talk about today. The fifth are the aminoglycosides. Then you got to know your steroids, your calcium channel blockers, your beta blockers, your pain meds, and your OB drugs. Those are the big 10, and we hit all of them. Okay, so these are real, real important to know. Now, here's the deal. For aminoglycosides, think the following. A mean old mycin. When you see the word aminoglycoside, from now on, I do not want you to think aminoglycoside. I want you to think a mean old mycin. Do you hear the similar sound? Amino, amine old. Amino, amine old. So when you see aminoglycoside, think what? Amine-old mycin. Okay, now, what does that tell you? Well, here's what that tells you. The letter B, they are antibiotics used to treat what? Well, if they are mean, old drugs, what kinds of infections would they treat? Serious or non-serious? Life-threatening or non-life-threatening? Resistant or susceptible? Gram-positive or gram-negative? Gram-negative. So you got the resistant, serious, life-threatening, gram-negative infections are treated by what? A mean old mycin. So you treat a mean old infection with the mean old mycin. Do you hear what I'm saying? So would you use these drugs to treat sinusitis?
No.
Why?
It's
It's not a mean old infection, so don't use a mean old glycoside. What about tuberculosis? Ooh, that's a mean old infection. I use a mean old mycin. What about septic peritonitis?
Yeah.
Is that a mean old infection? Yep, so I use a what? A mean old mycin. What about otitis media?
No.
Middle ear infection. Is that a mean old infection?
No.
No. Do I use a mean old mycin? No. What about bladder infection? No. What about fulminating pyelonephritis? Yeah. Septic shock.
Yeah.
Infection of third-degree burn wounds over 80% of your body.
Yeah.
Got it? What about viral pharyngitis?
No.
Strep throat?
No.
No. So use a mean old mycin when you got a mean old infection, and never any other time. So mean old tells you what it treats. Mean old infections. The mycin tells you what they end in. Good news. All aminoglycosides end in mycin. They all do. And that's letter C. All aminoglycosides end in mycin. But you know what the bad news is? Not all drugs that end in mycin are aminoglycosides. Rats. Wish that would work, but it doesn't. But don't despair, because most drugs that end in mycin are mean old mycins. There are 3 of the mycins which are not these drugs. And the 3 mycins which are not mean old mycins, are erythromycin, zithromycin, and clarithromycin. What do all the mycins that are not mean old mycins have in them? Thro. So I say, if it ends in mycin, it's a what? Mean old mycin. But if it has throw it off the list. Do you hear what I said? If it ends in what? Mycin, it is a mean old mycin. But if it has throw in it, throw it off the list. It is no longer a what? Mean old mycin. So would you use clarithromycin, zithromycin, and erythromycin for sinusitis?
Yeah.
Yes. Would you use it for tuberculosis?
No.
Would you use streptomycin for otitis media, sinusitis?
No.
Would you use it for tuberculosis? Yes. So the mycins are mean old mycins, except the thromycins, which are little old, harmless, no big deals. So watch out for your thromycins. They're a little tricky. So if you see thromycin, do what with it? Throw it off what list?
The
The mean old list, so it's just a little old. Some examples: clindamycin, cliomycin, bleomycin, dactinomycin, adriamycin, streptomycin, kanamycin, bleomycin. You know, all these mycins. Now, what are the toxic effects? Letter E. This is what they really key in on. What are the 2 toxic effects? Now, what do all these drugs end in? Mycin. What English word sounds like mycin? Mice. So when you see mycin,